Great. Thank you so much. Okay, I'm gonna start. Hello, everyone. Today we're gonna talk about transcranial Doppler. Since last time or last talk I've given, it was related to non-invasive neuro monitoring, especially we're talking about the optic nerve sheath diameter. So today I thought it might be nice to talk a little about TCDs since we usually use them quite often on our PICU. So today we're gonna cover a few topics or few headlines, introduction, and then some of the applications that we tend to use TCDs for, the technique, interpretation, and some of the limitations to this tool. So obviously, transcranial Doppler is a non-invasive ultrasound technique to measure the cerebral blood flow velocity, and it was first discovered or maybe start to be implemented in early 1980s to measure cerebral blood flow velocity and the large cerebral arteries around the circle of Willis, which we will see in a second. Some of the applications that we tend to use TCDs for, we could, for example, say ischemic cerebrovascular diseases such as sickle cell disease and the risk of stroke that is associated with this specific disease. And the way they usually monitor this or use TCD for this specific disease, they usually assess the need for transfusion and the risk of cerebral ischemia, obviously. And this is usually done through assessing the cerebral blood flow velocities, because as we know, in sickle cell disease, you get anemia and maybe the hemoglobinopathy as well. Both can cause increased blood flow velocity in the cerebral vessels, and that can somehow cause strokes. And then they use TCD to assess the need for transfusion for this specific matter. The other thing is cardiac patients, specifically right to left cardiac shunts. And it's usually done more in adults where they do TCDs while doing agitated saline tests to see the right to left cardiac shunts and how much of this agitated saline actually goes to the cerebral arteries through scanning the MCA while doing this specific test. AVM as well, arteriovenous malformation, is one of the things that we usually could do TCD to kind of see the impact or how much the velocity, because we know that if there is a fistula or malformation, and the velocity will be higher because now there is less resistance downstream in front of the arteries. Other stuff could be neurological or neurosurgical intensive care monitoring, like what we usually get after a subarachnoidal hemorrhage, which is usually a local vasospasm, where you will get a higher velocity in the specific scan vessel. Another thing is usually TBI, which we usually encounter quite a lot here in our PICU. TBI, actually, or traumatic brain injury, can cause variant or different impacts or effects over the vessel. So usually in the very early phase, maybe day 0, you could get hypoperfusion of the cerebral or over the brain tissue. And then on days 1 to 3, you could develop hyperemia. And then onward, you can develop vasospasm as a result of the injury. Other thing that you can look for is the cerebral or you can detect with the TCD is the cerebral circulatory arrest or brain death, because we know that during doing brain stem testing could be affected by various factors, like, for example, electrolytes. EEG as well can be affected by benzos and sedation. So TCD can give you a good insight regarding the cerebral flow and the circulatory status for the cerebral perfusion. Others could be cerebral pressure autoregulation, and by autoregulation we usually refer to the maintenance or the ability of the brain to maintain its cerebral blood flow despite changes that might happen in the cerebral perfusion pressure. TCD can help us assessing this specific feature of the brain through getting what we call mean flow index. And the mean flow index is usually derived from the moving correlation coefficient between two things. One is the mean flow velocity in the cerebral arteries, and the second thing is these either cerebral brain perfusion or the arterial blood pressure. So you get your mean flow index from those indices, and then you obviously do this, or you get this through the TCD, and then that gives you an insight about the brain ability for autoregulation that is usually get affected with different and various injuries. So here's talking about the technique we have for usually the well-known windows for scanning or getting your TCD scan done. Transtemporal, and this is the most common that we usually use in our PICU. And then transfontanel is more common in neonates where they still have an open anterior fontanelle, suboccipital and supraorbital as well, and both are usually done more in adult population. So through the transtemporal, you could scan the MCA or the anterior cerebral artery or the posterior cerebral artery, but usually the middle cerebral artery is the preferred one, and that is mainly because of the direction of the blood that actually goes towards your probe, so you don't need to angle too much with the probe, and then you can get actually specific or accurate numbers, if you will, through scanning this specific artery. Through transfontanel, we used to get Doppler results from the MCA, and through the suboccipital window, which is usually transforamen, the beam goes through the foramen magnum, and then you can scan your vertebral or basilar arteries. And the supraorbital window, you can get results from the ophthalmic artery. Here's a reminder of the circle of Willis anatomy. As you can see, here is the MCA, the one that travels laterally towards your probe if you're scanning through the transtemporal window. And then you got the anterior cerebral artery and the posterior cerebral artery right here. All of those three arteries you can access through the transtemporal window, and then you've got your ophthalmic artery, which you can access through the suborbital window, and then you've got the basilar and both the vertebral arteries, which you can access through the transforamen or the suboccipital window. All right, so for the technique itself, you usually use the phased array probe, which is the cardiac probe, and the reason why, because the beam actually starts very narrow and then it diffuses along through the journey, so it can get you a good image, because we're actually accessing through the temporal bone, which is actually a bone. There is no gap here, but it's just a thin bone, so you would like your beam to be as small as possible, penetrating this part, and then it diffuses along through the course, and then it gives you the image. So you start with directing the probe knob toward the patient's eye. It's either right or left, whatever side you're scanning. Usually start with the knob towards the eye of the patient, and then you can put your probe like here just in front of the ear, and slowly and slightly go up all the way like here, just above your zygoma or whatever you call it, and then until you get this beautiful view, the butterfly view as they call it, which is actually basically the cerebral peduncles or the peduncles of the midbrain. Once you get this view, you could tilt your probe up and down, just fanning, in order to visualize and to get the best image quality that you can get. And then obviously you could put a color Doppler on this specific. Once you get this view, then you should put a color Doppler in order to visualize your arteries. As you can see here, we actually had the middle cerebral artery right here colored in red because the blood flows towards my probe, that's why it's red. And then the anterior cerebral artery right here, and again it's blue because the blood flows that way toward the eye, which is a bit away from the probe, hence the blue color. And then you've got your posterior cerebral artery running like here. And for a better visualization of the circle of Willis, this one could give you a better imagination about what is going on and what does it actually look like on ultrasound with a proper color. But usually the color is not this, it's just for illustration, but just to get a good idea. So here's the MCA, or the middle cerebral artery, again the ACA, and then the posterior cerebral artery. And you obviously get a bilateral view because you're traveling all the way from one side all the way to the other side. So you get bilateral cerebral visits. Once you get your color Doppler and then you're happy with the MCA appearance, and then you put your pulsed wave Doppler on it, and then you move your gate until you should put it on right on the middle cerebral artery, and then press the pulsed Doppler or pulsed wave Doppler once again in order to get your beautiful waveform and the number that your machine can get to you very automatically. So as you can see here, you get some velocities, and of those will be the mean flow velocity, the peak systolic velocity, and the end diastolic velocity. And then you get a couple of resistance indices. Those are the resistance index and the pulsatility index, as you can see here. And then you got the waveform or the flow direction, and you use all of those parameters basically to interpret your results. As you can see, this constitutes one cardiac cycle, and its components are, one is the systole, which ends somewhere here, which is a sharp systolic spike, and then you get beautiful slow diastolic deceleration, as you can tell from here, and it starts somewhere here and then goes all the way until the end diastolic velocity. And obviously the peak of this is the peak systolic velocity. And you could get the mean, or the mean can be obtained automatically by the machine itself. Right, some of the factors that might affect blood velocity. So if you've got, for example, a reduced Doppler flow velocity, that could be as a result of hypoperfusion, reduced mean arterial pressure, which does make sense. Hypocapnia as well, due to the fact of the cerebral vasoconstriction that happens as a result of the low CO2, and thiobenton as well is known to cause low velocity. Some of the things that might increase your Doppler flow velocity would be one, hypoxemia, anemia, because now we've got less hemoglobin, and then your blood is actually more thin and hence can travel faster, so your velocity will go up. Fever can cause hyperdynamic circulation, obviously. Hypercapnia will cause cerebral vasodilatation, so the blood will go even more and more velocity as a result. And then finally, vasospasm secondary to subarachnoid hemorrhage, which is usually a local vasospasm. And if you think about it, if you've got a beautiful tube or a vessel, and then you press on this vessel or tube partially, you will get higher velocity flow inside this specific stenotic or spastic part, which is usually secondary to subarachnoid hemorrhage. Right. So let's talk about interpretation. Here is a quick comparison between three of the things that we might encounter: hyperemia, vasospasm or stenosis, and then usually we don't see stenosis, but we might see vasospasm, and then finally high ICP, which we quite encounter frequently in our ICU. So in hyperemia, basically there is more blood in the cerebral circulation, so your velocity will be high. So anything above 120 centimeter per second will consider to be high velocity. And then in a vasospasm state, again, you'll have high velocity, high flow velocity state. while an ICB could be any, basically. It could be high, normal, or low. And then talking about resistance, for resistance index, if it's hyperemia again or vasospasm, the resistance, the downstream resistance will be relatively low in comparison to the ICB, which will for sure go up, because if you think about it, if you have high pressure inside the cranium, that will create more resistance against the blood flow to travel across. So you'll get high resistance index, and the same goes for pulsatility index, because both gives you an insight about the resistance against the flow of the blood. So again, the same parameter will be low for both hyperemia and vasospasm, and high for high ICP. Here's an interesting thing, the Lindegaard ratio, which is usually a ratio that is used to differentiate between both states, hyperemia and vasospasm. Because obviously, as you can see, both have the same parameters, more or less. Both have high flow velocity, and both have low resistance and pulsatility index. So the way you differentiate between both is usually do this Lindegaard ratio, and it's usually calculated. It is a calculated ratio of the highest mean velocities in the middle cerebral artery and the ipsilateral extracranial internal carotid artery. So the ratio between both compares inflow to outflow and determines the presence of vasospasm versus hyperemia. Because if you think about it, hyperemia, you should have high flow velocity both in the MC and the internal carotid artery, because there is hyperemia, global hyperemia, while in vasospasm you will get only high flow velocity in the MCA, while normal velocity in the ICA, because it's again local. And then if you put the MCA values over the ICA values in hyperemia, it will be less than 3, because now you have got the difference is not great, but in vasospasm, because you've got high velocity in the MC compared to the ICA, so the difference will be quite high. It should be more than 3, and then you can actually differentiate between both states. Diastolic blood flow, usually normal or high in both hyperemia or vasospasm, and obviously very, very low in high ICP, as we will see in a second. And the risk, as you can see, hyperemia could cause you cerebral edema or bleed, while vasospasm is a great risk for stroke, and a high ICP can actually be bending for coning or death, as you all know. Right, those are some of the normal velocity values for MCA and internal carotid arteries across different ages, as you can see. So you could have a look. Here's the Tmax or velocity max. And then here's the peak systolic velocity and the diastolic and diastolic velocities. So talking about resistance and pulsatility index, as you can see, normal value for resistance index is usually for children something between 0.43 to 0.58. And the difference between both is usually a calculation thing. So for resistance index, the way you get it is usually the difference between, or delta pressure, difference between peak systolic velocity and the end diastolic velocity over the peak systolic velocity. While in pulsatility index, the same, the difference of velocity over the mean velocity, which is not in the resistive index. And the normal values for the pulsatility index is usually 0.7 to 1.1. And we usually rely more on pulsatility index, or use it more, scanning or getting transcranial Doppler through the MCA. Right, here are some of the waveforms that you might encounter. So if you can see to this graph, you can see beautiful systolic waveform, and then slow deceleration of the diastole, and you've got a good end diastolic flow velocity. And the more you go that way, by making the systolic waveform more spiked and more sharp, and less diastolic velocity, the more you get higher ICB and less cerebral brain perfusion, obviously. So if you get this, here, for example, high ICB, but you still got some diastolic forward flow, while if your ICB is actually more than the diastolic blood pressure, then you will have no forward flow in the diastole. And this you can see if your ICB is actually as great as your MAP, then your diastolic flow will be reversed on basically. Because if you think about it, usually diastolic pressure is less than the map. So if the ICB is actually equals the map, then that will be higher pressure than in during the diastole phase, which will cause reversed flow of the diastole. And the same goes here, as you can see. And obviously, if you've got this waveform that is very sharp spikes, systolic spikes, and reverse diastolic waves, this is a usual indication or an evidence of cerebral circulatory arrest. Again, here's a normal, beautiful TCD waveform with a beautiful peak systolic flow velocity and then slow deceleration of the diastolic phase, and then here decreased diastolic flow. Here you've got reversal diastolic flow, while here you only got some systolic spikes in a brain dead, obviously. Some of the limitations of the TCDs, usually as anything else, operator dependency, maybe the difference between expertise and that specific issue, which is usually overcame by practice and doing more of the procedure or the technique. And then you've got some patients might have limited acoustic windows, which might challenge us doing the exam, and then interpretation challenges for various reasons. And then, as usual, TCD should be considered as a complementary rule. So we usually not rely 100% on it solely. We put it in the whole bigger picture, considering the clinical picture of the patient and other neuromonitoring tools that we might use in order to get a accurate insight about the patient. And yeah, that was it.